Hello everyone and welcome to our module on diuretics. Diuretics are drugs that increase the urine output, and there are 5 classes of drugs that have this effect, and we'll go through each of them in this video today. Before we talk about specific classes of diuretics, let's review some general principles that apply to many of the drugs we're going to talk about in this video. The first one has to do with sodium. A normal plasma sodium concentration, as you may know, is about 140 milliequivalents per liter. And this plasma sodium concentration is tightly regulated by the renin-angiotensin-aldosterone system and also by the ADH secretion by the pituitary gland. What this means is that anytime you take in more sodium in your diet, your body will retain water to balance that sodium and maintain the plasma sodium concentration at about 140 milliequivalents per liter. This also means that anytime there is sodium loss from the body will excrete water and once again maintain that normal plasma sodium concentration of 140 milliequivalents per liter. And if you understand this, you should be able to appreciate that any drug that increases sodium excretion by the kidneys will lead to water and volume loss and will increase the urine output, which is what diuretics do. Therefore, many diuretics work by increasing the sodium excretion by the kidneys. This always leads to a loss of water in order to maintain that normal plasma sodium concentration. Another principle of diuretic effects has to do with potassium. Potassium is secreted in the nephron by the distal tubule and the collecting duct, as I've shown in this picture right here. And the amount of potassium that is excreted by this section of the nephron varies with the sodium and water delivery to the distal nephron. This is a very important principle of nephron function for you to appreciate. What this means is that anytime there's more urine flow, meaning more sodium and water delivery to the distal nephron, there will be more secretion of potassium. And thus, most diuretics lead to hypokalemia. This is because they all increase the urine flow, therefore they all raise the sodium and water delivery to the distal nephron, and that leads to more potassium excretion in the urine. With those principles in mind, let's talk about our first group of diuretic drugs. Those are the carbonic anhydrase inhibitors. In the video on nephron physiology, I talked about how the enzyme carbonic anhydrase is required for the reabsorption of bicarbonate and sodium in the proximal tubule of the nephron. What this means is if you inhibit the effects of carbonic anhydrase, more sodium and bicarbonate will go out in the urine. And as we talked about before, anytime more sodium goes out in the urine, it takes water with it and produces a diuretic effect. There's one drug in this class that's used clinically. It's called acetazolamide. This is its structure shown on the screen here. Acetazolamide is a weak diuretic. As I showed you on the last slide, it blocks sodium reabsorption in the proximal tubule, but most of the distal parts of the nephron will reabsorb that sodium, and thus the diuretic effect it produces is relatively weak. It also causes a non-anion gap metabolic acidosis. It increases the elimination of bicarbonate by the kidneys, as I showed you on the last slide. That leads to a metabolic acidosis. Because its diuretic effect is so weak, acetazolamide is never used as a diuretic. In other words, it's never used to increase the urine output. It's used in special niche situations. One of those is severe metabolic alkalosis. This is a rare condition, but when it does occur, acetazolamide, by causing a metabolic acidosis, can reverse the alkalosis. It's also sometimes used in glaucoma. You need carbonic anhydrase for normal formation of aqueous humor. So when you inhibit carbonic anhydrase, you block formation of aqueous humor in the eye. It can also be used in pseudotumor cerebri. This is intracranial hypertension. Carbonic anhydrase is necessary for normal formation of cerebrospinal fluid. So when you administer acetazolamide, you reduce the rate of CSF formation. And then finally, it can be used to prevent high altitude sickness. When you ascend to a high altitude, like when you climb a mountain, there's a low pressure of oxygen at high altitude. This stimulates hyperventilation. The hyperventilation lowers the carbon dioxide level and causes a respiratory alkalosis, and this contributes to the symptoms of high altitude sickness. Acetazolamide, by causing an acidosis, reverses the alkalosis, and it can minimize some of the symptoms of high altitude sickness. Side effects of the carbonic anhydrase inhibitors include a metabolic acidosis. If you give acetazolamide to treat glaucoma, you need to be aware that the drug will cause a metabolic acidosis. In addition, acetazolamide can cause paresthesias. This often presents as tingling in the extremities. Paresthesias are common in a number of acid-base disorders and are believed to be due to acid-base disruption effects on nerves. And then finally, acetazolamide is a sulfonamide drug. Therefore, patients who have a sulfa allergy need to be aware that they can have an allergic reaction. The drug does contain a sulfonamide moiety. Another side effect of acetazolamide, one that's very high yield for you to know for step 1 of your boards, is that the drug can cause kidney stones. The reason for this is because carbonic anhydrase inhibition reduces urinary citrate excretion. Recall that citrate is an intermediate in the TCA cycle. You also get it from your diet. It's excreted in the urine and it inhibits the formation of calcium stones. So anything that decreases the amount of citrate excretion in the urine will make it more likely that calcium kidney stones will form. And just by way of reminder, here's a slide from our biochemistry module showing the TCA cycle, and citrate is one of the intermediates in the TCA cycle, and it is very helpful for preventing formation of kidney stones. Our next class of diuretic drugs are the osmotic diuretics. These drugs work on the thin descending limb of the loop of Henle. Recall that this portion of the loop of Henle concentrates the urine. In other words, it absorbs water, pulling it out of the nephron. This section is impermeable to sodium chloride, so water leaves the urine, drawn out by hypertonicity in the medulla. As fluid moves down through the nephron here, water is coming out, and therefore you have a very concentrated urine at the base of the loop of Henle. And just by way of review, and this will be important later when we talk about loop diuretics, the reason that water is pulled out of the nephron is because the osmolality is very high in the outer and inner medulla. The osmolality in the cortex surrounding the nephron is about 300 milliosms. This osmolality is maintained by urea, sodium, and chloride. The osmolality gets higher, as high as 1200 milliosms, when you get down to the inner medulla. This means that as fluid moves down through the nephron, these high concentrations of solutes are pulling water out as the fluid moves along. There's one osmotic diuretic that's used clinically. It's called mannitol. It's a sugar alcohol, meaning it's composed of carbons and alcohol groups. This is its structure shown on the screen. It's freely filtered by the glomerulus. It's not reabsorbed by the tubules. Therefore, it will raise the osmolality of the fluid in the nephron. As a result, less water is drawn out in that descending loop of Henle, and this will increase the urine output. Let's go back to this slide and let's imagine some fluid moving down the nephron into the descending limb of Henle. Ordinarily, water would be drawn out in this portion, and the reason it's drawn out is because there is a big concentration difference of solutes between the fluid inside the nephron and the fluid outside the nephron. What mannitol will do is it will raise the osmolality of the fluid here inside the nephron. This means there will be less difference to pull water out of the nephron. As a result, less water is reabsorbed and there is more urine output, hence it has a diuretic effect. Much like acetazolamide, mannitol is generally not used for its diuretic properties. In other words, it's not used to increase urine output. The places where it's used are places where you want to draw fluid out of tissue spaces that are swollen. Before the mannitol reaches the glomerulus in the kidneys, it will circulate in the plasma. This will raise the osmolality of plasma and draw fluid out of tissue. So for example, in cerebral edema when there's swelling of the brain, or in severe cases of glaucoma, the mannitol will draw fluid out of either the brain or the eye, and that will lower the pressure in those tissue spaces. The goal is to create a hyperosmolar state in the body. This is called osmotherapy, and it draws fluid out of the brain or the eye. Once you understand that mannitol creates a hyperosmolar state, it's easy to understand why you cannot use mannitol in patients with heart failure. Mannitol will draw fluid out of the tissues, expand the intravascular volume, and in a patient with heart failure, this can lead to pulmonary edema. You also can't use mannitol in patients with severe renal disease. Part of the reason for this is because patients with severe renal disease cannot excrete the mannitol, so it will circulate in the plasma for prolonged periods of time. In addition, mannitol can cause renal failure. It's typically an anuric renal failure where patients make no urine. The reason for this is believed to be because mannitol can cause renal vasoconstriction, and this can lead to anuria. So if you give mannitol to a patient who already has severe renal disease, you can shut down their kidneys, make the patient anuric, and they can end up on dialysis. Our next class of diuretic drugs are the loop diuretics. These drugs work by inhibiting a pump in the thick ascending loop of Henle that reabsorbs sodium, potassium, and 2 chloride atoms. Let's review the role of this pump in a little more detail. This is a slide from our nephron physiology module. This is a cell in the thick ascending limb. We have the lumen of the nephron containing urine here, and we have the interstitium in the blood over here. So the sodium-potassium chloride pump will pull sodium, potassium, and chloride atoms out of the urine. Some of the potassium atoms will leak back into the lumen of the nephron, and this will contribute to a net positive charge in the lumen of the nephron. That positive charge will drive positively charged cations like magnesium and calcium to be reabsorbed via the pericellular route. So the net effect is that this pump contributes to the reabsorption of sodium, potassium chloride, as well as magnesium and calcium. There are a number of loop diuretics. The one that is most commonly used is called furosemide. It also goes by its trade name Lasix, and it gets that name because the effects last for 6 hours. Other loop diuretics are bumetanide, torsemide, and also ethacrynic acid. They all inhibit the sodium-potassium 2 chloride pump. And what you need to know about these drugs to understand how they're used clinically is that these drugs produce a very strong diuretic effect. Of all the diuretics we use clinically, these drugs produce the greatest urine output, and therefore they're used in edematous states like heart failure and cirrhosis, where you need to remove lots of volume from the body. The reason they are such powerful diuretics is because they have two mechanisms to promote diuresis. First of all, they increase sodium excretion, as many diuretics do, but they also have a second mechanism to generate a diuretic effect, and that is that they decrease the medullary osmotic gradients. If we go back to this slide, water is drawn from the lumen of the nephron in the thin descending limb and also in the collecting duct. The reason it is drawn out of the lumen of the nephron is because you have a very high osmolarity surrounding the nephron. It can get as high as 1200 milliosms in the inner medulla. Well, what maintains that high osmolarity is the sodium-potassium 2-chloride pump. It's a major contributor to the osmolarity of the outer and inner medulla. Therefore, when you inhibit this pump with a loop diuretic, you not only send more sodium out in the urine by blocking the reabsorption of sodium, you also diminish these gradients so that less water can be reabsorbed by the thin descending limb and the collecting duct. As a result, you produce a very vigorous diuretic, and these drugs lead to significant volume loss much greater than the other diuretics that we use clinically. If you understand the mechanism of action of loop diuretics, it's very easy to remember their adverse effects. These drugs block the reabsorption of potassium, calcium, and magnesium. Therefore, they can potentially cause hypokalemia, hypocalcemia, and hypomagnesemia. In addition, most of the loop diuretics contain a sulfonamide group and therefore are sulfa drugs. For example, furosemide has a sulfonamide group that I'm circling here. For this reason, patients that are allergic to sulfa drugs can potentially have an allergic reaction to furosemide or other loop diuretics. The one exception is ethacrynic acid. This is the structure of ethacrynic acid at the bottom right side of the screen. It does not contain a sulfonamide group, therefore it can be used in patients with severe sulfa allergies. The other side effects of loop diuretics are not so obvious. These drugs can potentially cause ototoxicity. This is very rare. It only occurs with very high dosages, or if you give a loop diuretic together with another drug that's ototoxic. It can present as tinnitus and loss of hearing, and it's usually reversible when you stop the drug. Loop diuretics can also potentially cause acute interstitial nephritis. I talk about this in detail in the video on tubulointerstitial disorders. This is essentially an allergic reaction that occurs in the kidneys. It presents as a rising BUN and creatinine with white blood cell casts in the urine and urine eosinophils. And then finally, loop diuretics can precipitate attacks of gout. Gout, as you may know, is a form of arthritis. It commonly involves the foot, as shown in this picture on the screen, and it can be caused by high uric acid levels. Uric acid has a complex mechanism of handling by the kidneys. All that you need to know is that the thiazide diuretics, which we'll talk about next, and also the loop diuretics both increase uric acid reabsorption. Thus, they can raise the uric acid level, and they can both potentially cause an acute attack of gout. Loop diuretics can also lead to a metabolic alkalosis. I discussed this in detail in the acid-base videos, but I'll just briefly review that a metabolic alkalosis is when the pH is greater than 7.45 and the plasma bicarbonate level is increased. The way this happens in patients on loop diuretics is that the diuretics promote urine output, and this lowers the effective circulating volume. This activates the renin-angiotensin-aldosterone system, and via a number of mechanisms, the renin-angiotensin-aldosterone system promotes acid excretion by the kidneys, and this leads to a metabolic alkalosis. This is sometimes called a contraction alkalosis because the effective circulating volume is contracted or decreased. And this can occur with both loop diuretics and thiazide diuretics. They can both lead to a metabolic alkalosis via renin-angiotensin-aldosterone system activation. Moving on, next we'll talk about the thiazide diuretics. These drugs work on the distal convoluted tubule of the nephron, as is shown on the screen here. These drugs inhibit sodium and chloride reabsorption from the lumen of the nephron, and as we talked about earlier, anytime the kidney excretes more sodium, water goes with it and a diuretic effect is achieved. In contrast to loop diuretics, which can cause hypocalcemia, thiazide diuretics produce a hypercalcemic effect. The reason for this is that when you inhibit sodium reabsorption from the lumen of the nephron, sodium continues to be pulled out by a sodium-potassium ATPase pump. This produces a very low level of sodium inside the cell. This will draw sodium into the cell in exchange for calcium via a sodium-calcium antiporter that is present in the distal convoluted tubule. This will lead to overall more reabsorption of calcium when you inhibit sodium reabsorption with thiazide diuretics. All of the thiazide diuretics are sulfa drugs. They all contain a sulfonamide group, like I'm circling with my pen here. Therefore, in patients who are allergic to sulfa drugs, they can potentially have an allergic reaction to a thiazide diuretic. Thiazide diuretics elevate the blood levels of a number of substances. They produce a mild increase in the blood glucose level. They can also mildly increase the plasma lipid levels, Both of these effects are small and usually not clinically significant. As we discussed previously, they can raise the uric acid level just like loop diuretics and potentially cause an acute attack of gout. We've also discussed previously how they raise the calcium level, and many people remember these effects by the mnemonic hypergluc. And because of these effects, you have to be cautious when using these drugs in patients with diabetes, hyperlipidemia, gout, or hypercalcemia. They can potentially worsen these conditions. Thiazide diuretics are notorious for causing hyponatremia. The reason for this is because these drugs promote sodium loss, but they leave the ability to reabsorb water by the nephron intact because they leave those medullary gradients intact. This means that if a patient's on a thiazide diuretic and they take in too much water, they can end up in positive water balance, and this leads to hyponatremia. If we go back to this slide showing the osmolarity of the different portions of the kidney, thiazide diuretics block the ability to reabsorb sodium in the distal tubule. Because this is blocked, more sodium will go out in the urine. This is called negative sodium balance. The ability to reabsorb water, however, is normal. All these gradients are normal, and therefore patients taking thiazide diuretics can absorb water as they usually would. What this means is if a patient on a thiazide diuretic drinks excess water, they will reabsorb all that water at the same time as they are losing sodium in the urine. And this is a setup for hyponatremia, and this is why hyponatremia is a common side effect of patients taking thiazide diuretics. And then as we discussed previously, any diuretic that delivers more sodium and water to the collecting duct can cause hypokalemia. We've also discussed previously that drugs which reduce the effective circulating volume can cause a contraction metabolic alkalosis, and this is also seen in patients on thiazide diuretics. The main clinical use of thiazide diuretics is in hypertension. These drugs don't produce a vigorous urine output, so they're not useful for conditions like heart failure and cirrhosis, where you need to remove lots of volume from the body. However, in hypertension, the mild decrease in effective circulating volume caused by the drugs often leads to a reduction in blood pressure, and especially hydrochlorothiazide is very commonly used for hypertension. These drugs are also helpful in patients with recurrent calcium kidney stones because they pull calcium from the urine. They're also useful in osteoporosis because they increase the plasma calcium level, and this can be helpful to the bones. And then finally, they're used in diabetes insipidus because they lead to increased reabsorption of water by the proximal tubule, and I discussed this effect in more detail in the video on sodium disorders. Our final class of diuretic drugs are the potassium-sparing diuretics. Drugs in this class include spironolactone and eplerenone, which both function by blocking the aldosterone receptor site. In other words, they directly block the effects of aldosterone. Other drugs in this class include triamterene and amiloride. These block the aldosterone sodium channel. They don't block the effects of aldosterone itself. I'll show you a picture of this in a minute. And these drugs are obviously a good choice for patients with hypokalemia, especially patients on other diuretics. Other diuretics like thiazides and loop diuretics cause hypokalemia. If you add a potassium-sparing diuretic, you can blunt the problems the patient will have with low potassium levels. Here's a slide from our nephron physiology module showing you the pumps and channels in the principal cells and intercalated cells of the collecting duct. Aldosterone is a hormone, and it functions on both of these cells to increase the number of sodium channels, to increase the number of sodium-potassium ATPase pumps, and increase the number of hydrogen ion pumps. So the drugs that block the effects of aldosterone, like spironolactone and eplerenone, block aldosterone from placing all these channels and pumps in the cell membranes. The other potassium-sparing diuretics, triamterene and amiloride, block this sodium channel that aldosterone incorporates into principal cells. But both drugs have the same effect. They block the reabsorption of sodium in the collecting duct. They also block the excretion of potassium, and that's why they're called potassium-sparing. So just to summarize, all of these drugs increase sodium and water excretion, and therefore they are diuretics, and they all spare potassium, which means unlike other diuretics, they do not increase potassium excretion. And in fact, all of these drugs block potassium excretion by the kidneys. This means that hyperkalemia is a potential side effect, and that's in contrast to a lot of other diuretics, especially loop diuretics, where hypokalemia is a side effect. A special word on spironolactone: it has a number of peculiar side effects that can be hard to remember, but I'll give you an easy way to keep them straight. Spironolactone structure is shown at the bottom of the screen here, and you can see that it has a very similar chemical structure to the steroid hormone testosterone. And if you know this, that's an easy way to remember that spironolactone blocks testosterone effects. In men, this can lead to a situation where there are relatively more estrogen than testosterone effects, and this can lead to gynecomastia. This is a picture of a man with gynecomastia on the screen here. This happens to about 10% of men who take spironolactone. The major advantage, by the way, of eplerenone is that it is an alternative to spironolactone. It's got a chemically modified structure, and it does not cause gynecomastia, so it can be used in men who need a drug like spironolactone but who develop gynecomastia on spironolactone. Another thing to remember about spironolactone is that it is a derivative of progesterone. This is progesterone at the bottom right side of the screen here. Progesterone is chemically modified to make spironolactone. And if you know that, then it's an easy way to remember that spironolactone can potentially activate progesterone receptors, and in women this can cause amenorrhea. When progesterone receptors are activated, this is the same circumstance as occurs in pregnancy, so women therefore will not menstruate. I'll finish this module with some general points about diuretics. All diuretics can potentially cause renal failure. The reason for this is that by increasing the urine output, diuretics decrease the effective circulating volume. This can lead to a fall in the glomerular filtration rate, and if the GFR falls by too much, BUN and creatinine may start to rise in the plasma and acute renal failure can potentially develop. Diuretics can activate the renin-angiotensin-aldosterone system. This occurs because diuretics result in volume loss, and volume loss stimulates the renin-angiotensin-aldosterone system. This in turn leads to increased sodium and water reabsorption by the kidneys, and what this means is that there is some adaptation to the diuretic effect over time. Finally, I'll leave you with a couple of rules of thumb. All diuretics except the potassium-sparing diuretics increase potassium excretion, as we discussed at the beginning of this video. The carbonic anhydrase inhibitor drugs and the potassium-sparing drugs all cause acidosis, meaning they lower the pH. This happens from the carbonic anhydrase inhibitors because they increase bicarbonate excretion. The potassium-sparing drugs can do this either by blocking the effects of aldosterone or through hyperkalemia. Anytime there is hyperkalemia, hydrogen ions and potassium ions can be exchanged via a cellular antiporter, and this can lead to acidosis. All the other diuretics like thiazides and loop diuretics cause a contraction alkalosis. In other words, they raise the pH. And then finally, loop diuretics and thiazide diuretics have opposite effects on calcium. The loop diuretics cause hypocalcemia and the thiazide diuretics cause hypercalcemia. And that concludes our video on diuretics.